Hello, my name's Leanne Hassett. Welcome to another Worldwide Journal Club from PEDro. Today we're going to be talking about a randomised controlled trial led by Professor Gavin Williams on ballistic strength training in people after traumatic brain injury. So I'm going to start by introducing the panel. I'm Leanne and I'm from the University of Sydney and a physio background. I'm also a member of the PEDro Education and Training Committee. Now we've got Chris. Chris, would you like to introduce yourself, please?
My name's Chris Byrne. I'm an senior exercise physiologist at Epworth Healthcare in Melbourne. My experience in TBI spans some 25 years now.
Great, thanks, Chris. And Tom?
Hey, my name is Thommo. My experience in this is that I am the occupation with the brain injury.
Thanks, Tom. And Jayden?
Hi, I'm Jayden Smileski. I'm a physiotherapy student at the University of Sydney, and I'm a student member of the PEDro Education and Training Committee.
Great. And Gav?
Hi, I'm Gavin Williams. I am a physio as well. I work across Melbourne Uni and Epworth Hospital and led this trial of ballistic training.
Great. Thanks, Gav. So hopefully you have had a look at the paper which Gavin led on to describe the results of the trial, and also that you've had a chance to watch the video that Gavin did, giving a bit more detail about the trial. So we're just going to, as a panel, just have a bit of a chat about, get into a bit more of the details of the intervention and the trial results. So I'm going to start with asking a question to Gavin. So Gav, can you just sort of go through the intervention in a bit more detail? And, I guess interested in both the ballistic training group, but also the usual care group. And I guess, is there any sort of really core elements of the intervention that are essential for it to be successful?
Sure. So firstly, our control group, we're a pretty active control group. And bearing in mind, we were recruiting people out of rehab centres, and they were primarily inpatients. So and they were typically having 2 sessions of physio a day, and so 3 times a week we'd substitute one of those sessions for either the intervention group or the control group. The control interventions were based on what we knew from the literature and observation studies. So they were doing cardiovascular training, balance training, stretching. But they're also doing, what we might call traditional resistance training. And one of the reasons for this trial was that, there's quite a bit of evidence now that weakness is one of the main problems limiting impairment, but traditional resistance training, which is typically done slowly and with heavier resistance, had not translated to improved mobility outcomes. So the key difference between the 2 groups was that the intervention group were doing ballistic training. And ballistic or fast strength training, or power training it's sometimes called, is basically just one aspect of task-specific resistance training that you see in the American College of Sports Medicine guidelines. So what we were trying to do was just target these exercises to the main muscles responsible for forward propulsion in a way that they contract, when people are walking. So we're just trying to match that as best we can. And one of the key things in terms of matching that was the speed at which people were doing the exercises. So that was the key difference.
Right. So Chris, as a clinician in a brain injury unit, you've had some experience delivering this type of intervention. What's your experience?
Well, I think that there's an increasing use of ballistic training within our therapy methods now, and I think Gavin's article and the research group is that it sort of lends support to the idea that we're matching biomechanical demand with neuromuscular demand, which I think is really important. But also, from my perspective, it also confirms that strength acquisition or increasing muscle strength isn't just an individual phenomenon, but that's reliant on other features, intramuscular features and intermuscular features. And we see that, and I think it was quite poignant that in the study where we had at the 6-month mark, where we had 2 groups with even strength levels or equivalent strength levels, but there's obviously an advancement in the rate of force production from the training group. So I think that's a really important aspect for me in terms of the concept of using it. And as I said, it's quite refreshing to see just matching task-specific and neuromuscular-specific functions together and have a meaningful outcome with it. From the perspective of delivering it, I think there's clinically, it can be challenging at times. It depends on the level of the individual that's undertaking the training program. In the early instances, it may be necessary to provide more hands-on facilitation of foot placement, for instance, landing control, motor control, and those aspects. And I think also something that's been alluded to in the study is that the application of load is very important, and judging the appropriate loads, because you want to maintain the speed of contraction. We're after the rate of force development. So if the load is too great, then the speed of contraction is at a loss. So we need to be able to monitor those things and judge those things very carefully. Similarly, within the training, I think what we need to do is manage the fatigue aspect and the quality of the movement very closely as well. So it comes down to the clinical level, I guess, in terms of being able to manage what observationally are you starting to get a decrement in the movement performance, and if that's the case, do they require a rest? And the other thing is, how long does a rest take before you get regeneration of the movement pattern and you can recommence again? So I think they're really important things in terms of the delivery of the program.
Yeah, great. And so, Tom, you've done this. You were a participant in this study. How did you find actually doing the ballistic training?
From what I can remember, which is obviously not a great deal, being so long ago, I remember that there was a lot of from ballistic, a lot of calf raises or like fast twitch calf movements, and also a fair bit amount of hip movements. Whether that'd be fast or not, I don't really know, but there was quite a bit of hip work and calf work.
Did you enjoy doing it?
No, not particularly.
But you did it, did you?
Well, yeah. Well, I didn't really have. I've done it. Yeah, I've done it. Yes.
Yeah, great.
Gavin, how do you determine the level to start the person at, and how do you know when to progress their training? And how does progressive resistance training fit with this?
Okay, so we'll go to the last bit first. So, like, if you look at the guidelines for a healthy able-bodied person, I would suggest that you do progressive resistance training prior to doing ballistic training or power training, because if you don't, you're going to get really, really sore. Okay, but we don't do that, and we don't really have a issue with DOMs, and I suppose it's because what Chris was talking about is that we're manipulating the load a lot. So in terms of where you start, in the trial, you had to be able to walk 10 meters, with close supervision, but hands off. In our clinical practice, though, we might have someone who gets, wheeled in by the orderly, and we slide them across onto the leg sled and we'll start doing ballistic stuff before they're, unassisted walking. Because, as Chris said, we're just trying to match how the muscles work to the biomechanics of walking and what the muscles are trying to do. So we would start as soon as possible and not really worry too much about getting a base of progressive resistance training first. you need to, I think, align your interventions with the guidelines for task specificity, but then you also have to have your progression principles. And so I think Chris said, if you load someone up, they just become slower and slower. So, you know, one of our guiding principles would be to de-weight someone. And so on a leg sled or a Pilates reformer, you can easily do that. And then once someone is working through the range that you want them to work through with the speed and timing and coordination you want them to work through, then we increase the load or resistance. But typically our experience is we need to reduce the load first so we can tick those other boxes and use the load as one of the things we progress with. Did I answer all parts of that question?
I think so, yeah.
Like, do you do a measurement, Gav, at all about what, the 1RM or anything like that to start them off?
No, it's problematic. So there's not a great clinical tool for measuring rate of force development or power. There's some new dynamometers you can that you can do that with, but it's problematic. And I suppose that's part of the attraction of progressive resistance training, is that it's very prescriptive. You do 3 or 4 sets of 8 to 12 reps or whatever, and you measure 1RM, and then you can remeasure that every 2-4 weeks, and then readjust the load and stuff. And it doesn't really work that simply with ballistic training, because I suppose as a guiding principle, if you're a healthy, able-bodied person and you're not doing the optimal strength training, you're still highly skilled in the way you move. And if you do increase your muscle strength, you may well benefit from a skill perspective if you're a sports person, because you've got skill. But our patients are not highly skilled. They're trying to relearn, motor skill and increase their muscle performance at the same time. So, like, I think, Chris and I would think about what we're trying to do, whether it's upper limb or lower limb, is the skilled application, the skilled or controlled application of force, trying to get the muscles to work as they should in performance. So we don't measure 1RM in relation to this, but we would measure performance, because the whole reason why you do task-specific resistance training is to improve performance. And so I suppose that's the bottom line. So in the absence of a good clinical tool to measure ballistic performance, performance is what we, are hopefully changing.
Just with regard to the HIMAT, like, I guess the last part of the question of is it widely used? It's well, we use it as a predominant base for measure of mobility, and as the studies alluded to, that as long as you've got someone who's walking independently without an aid, the HIMAT is a valid tool for commencement of use. But the other nice thing about it is that it represents the broad spectrum of mobility, and it has the 13 items across the scale. So we use that readily to be able to measure the capabilities of the individual when it comes to mobility performance. But I think an important feature of it is, from a clinical perspective, is that it also forms a strong clinical guide in terms of what you treat next in terms of the spectrum. So say, for instance, because it's hierarchical in its nature in terms of the task and the complexity of the task, and also the power generation that's required for each of the tasks, you can progressively work through that, particularly for newer clinicians. They can use that as a very informative guide to say, well, we've got to items 1, 2, 3, and 4, but we can see that items 5, 6, 7, and 8 are a little bit deficient at the moment. So therefore, we can focus our treatment sessions on those particular items, and make it very, very specific to the outcome, mobility outcome measures. So I think that's its real strength, is that, yes, we can quantify it and it gives us an idea of our treatment efficacy, but I think the real power of the HIMAT is the clinical guidance that it gives you as to where we go to next, because with a lot of our patients who have multiple impairments, and observationally, you look at them and think they're really hard to even sort of equate where do we begin. If you've got a tool like the HIMAT, at least it gives you a nice guidance or a clinical pathway to follow to guide your therapies.
Gav, do you have anything you want to add to that?
Only that I suppose when we were designing the trial, a key question for us was our primary outcome measure, which was the HIMAT, and the most common outcome measure for studies done in neurological rehab, regardless of the population, for mobility is the 10-meter walk test. So that was our secondary outcome measure. It's just that because we deal with a lot of young people with traumatic brain injury, they want to be able to do more than just walk. And it's pretty important to be able to walk when you can't walk, but once you can walk, then people want to be able to do something more than walk. So that's, I suppose, why we ended up using the HIMAT, because of measuring that scope of mobility recovery just below walking speed, because walking speed has a ceiling effect. You get to a certain walking speed, and it's natural to break into a run and then do higher level things which are important for participation and quality of life. So we were measuring those things as well. So that's why we selected the HIMAT.
Clinically, it's quick to use. In my experience when I was a clinician a while ago, it's so quick to use. You don't need much equipment. I think they're all really good things for selecting it for use in clinical practice as well. Yeah.
At the end of the intervention, the control group did better on balance measures than the experimental group. Throughout the study, did the intervention group do any balance training? And what's your take on the importance of balance and ballistic strength training for improving mobility?
Yeah, so the balance improvement in the control group was transitory. So at the 3-month follow-up, there was no difference in balance between the groups. The intervention group didn't do balance training in their intervention sessions, but they would have done it as part of their, other sessions during the week. But in terms of the role of balance in the recovery of mobility, it's interesting. There's not any great evidence that you can train balance to improve mobility. Depends partly on what you consider balance to be, though. So if you have someone standing on one leg, or standing on one leg with their eyes closed, or standing on a BOSU ball, that's obviously more and more difficult. But the skill is to stay still. Whereas mobility is about how quickly, efficiently, and effectively you can move your center of mass over a changing base of support, which is quite different. So there's no doubt that most of our patients have issues with their balance. But what we've found in a number of the studies that sort of led to this trial was that balance impairment is co-occurring rather than the key limitation. So in one study we looked at for people who are walking slowly after brain injury, we had them in the lab, and then after looking at their walking, then we assessed their fast walking. Now, for you to walk faster, your center of mass has to move from side to side less. You have to be more efficient at walking forward. And that's what the people with brain injury were able to do as well. They still move from side to side more than the healthy controls, but they were able to reduce that lateral movement. And in another preliminary study to this, we followed people up over 6 months and found that they had huge improvements in their balance over that 6-month period, but that improvement in balance was unrelated to the improvement of mobility at 6 months. So getting back to the trial, both groups improved their balance, because this trial was delivered in a subacute rehab phase. It's just that there was no difference between the groups at 3-month follow-up, and there was significantly greater improvement in mobility in the intervention group. So I suppose at the end of the day, you can't ignore the balance impairment, but you need to consider it carefully, but it's probably not a barrier to recovery of mobility.
So Gav, they had to do 3 times a week for 12 weeks. How did you manage with the dose that was required? Did they actually do as much as what you wanted them to do? And what about adherence?
Yeah, so adherence was good. Like we ran this through COVID, which is obviously an issue. And so that caused us a bit of a problem. But when we looked at the number of sessions done and the number of time on task within the sessions, it was equivalent between groups. So we had, good buy-in by the participants. But, dose is a problem, in terms of quantifying it, because, 20 repetitions of a ballistic exercise are not necessarily equivalent to 20 repetitions of progressive resistance training. And so because there's no equivalence there, we defaulted to measuring time on task. And so we had equivalent time on task for both groups, but it was just, it's more challenging, I suppose, to record dose for ballistic training because skill acquisition is occurring as well as the rate of force development as people recover, and so we weren't able to prescriptively say you're doing 3 sets of 10. The training volume would have been much higher than that, so we didn't measure it. We just measured time because at the moment there is no guidance around what an optimal dose might be for ballistic type training.
So Chris, you've delivered this clinically. How do you find people? Are you able to deliver a good dose and people generally adherent to how much you want them to do?
Yeah, I think just to echo Gavin's comments there as well, I think the dosage very much comes down to an individual basis. And something that we would always aim for within our sessions is that, and whether it's a combination of load and having matched velocity, that we need to be able to induce some sort of neuromuscular fatigue into the system, because ultimately what we're doing is we're trying to gain strength, but we're trying to gain it through force production. So we're working with a system that is demand and supply. So if the muscle groups or individual muscle groups require more neural transmission, then that will happen in accordance with fatigue. So if you don't take them into a fatigue state, the likelihood of you getting superior force neural transmission is going to be negated. So I think taking them to a volitional fatigue or a neural fatigue situation is a really important part of the ballistic training. And from a technical sense, it would make a lot of sense to be able to do that, because we know that particularly in the early stages of recovery, strength acquisition for our neurological population is very much a neurologically based phenomenon. It's not actually an architectural thing that happens within the muscle groups. So I think the more that we can increase the demand that is placed on the muscle, then in accordance, the central nervous system will have to comply with that demand. So I think that's what we're trying to do in that order. With regard to the adherence, I guess contrary to Tom's report, we don't have too many problems with people. People just recognise it as part of the therapy program with us, and it's mainstream activity for us. And there's probably a greater proportion of people who do ballistic training within our therapy than don't do it. So people have become accustomed to doing it just the same as they would just do conventional exercises. And if we go back to the value of using the high mat, is that most of our patients have a pretty good understanding of what the high mat means to them individually. And so we'll sit down with them and actually break down the high mat and educate them a little bit about what it is that they've achieved, and then what's achievable next. So I think as soon as you give them incentive in terms of being able to tick some boxes on a scale and being able to then relate that to their level of function and ability, you certainly get a lot of adherence that way. So I would say from extended experience, I would say that we don't really have that many problems with adherence. But I think the other thing for a clinician to make clear to their patient is that it's not going to be easy. It's going to be frustrating at times because of a lack of coordination, a lack of control. But then the intensity of it, as I said, we're trying to induce fatigue, so the intensity is up pretty high. So they're working at a pretty high intensity rate to do that. So there's a lot of effort attached to that. And for most of our patients, that's the hardest that they've worked since their injury or their accident. So bringing them on board with that and explaining that that's going to be a requirement of the treatment program, I think is a very important part.
What do you remember, Tom? Do you remember working hard doing it, and can you recall that you're sort of progressing through, and did it help you to maybe achieve some of your goals?
Yeah, worked extremely hard. They worked me to the bone. But it was well worth it. I look back now, it was well worth all the effort I put in for it.
And to give a little bit of perspective on Tommy's experience, he was a participant in the trial, but it was 6 months post-injury before he could actually walk independently. He then came back because he lives regionally and started our running group at 2 years post. And then at about 4 years post, he started doing fun runs and has now done a couple of half marathons. So, he's pretty impressive character.
It's very impressive. I wish I could have. My running feels like it's going backwards. So, well done.
Thank you.
That's great. But have you got a race coming up? Got a goal ahead?
I got next event on the calendar is in May.
Good.
So I'm
Right.
just training for that.
Right.
Gavin, your subgroup analysis showed a bigger effect on people with worse mobility at baseline. When do you think is a good time to start ballistic training with your patients?
So that was an interesting conversation we had before we started the trial, because in stroke, there's evidence for the people who are more impaired, may benefit less from intervention. So those walking less, slower than 0.4 meters a second. And we certainly had some conversations about, if the HIMAT was going to be the primary outcome measure, what was the, the bottom score that we'd let people in. And I was reasonably keen to let everyone in, if they could walk. And so there were some people who started with a score of 1, which is pretty, terrible. Some of them might have been taking a minute to do a 10-meter walk test, but as long as they could do it independently, they were in. So, so it was quite a somewhat surprising result that those who were more impaired at baseline did better. And honestly, we didn't know which way it would go. I just wanted everyone in. So those who are less impaired, maybe they've got more capacity to benefit. And so not really sure why that is. What interests me is that both groups did walking practice as part of the trial. So, they had 10 minutes allocated per session to actually, do walking practice. So that could have been, outside, over uneven surfaces, up and down gutters, just whatever is, usual rehab, mobility training that's relevant for that person. But we didn't let anyone do high-level mobility. So we didn't let anyone run, or join our running group if they were in the trial. And, maybe arguably those who may have had the capacity to run didn't do the relevant task practice. So if you couldn't run, then outdoor walking might have been a relevant task practice. And in the trial and in anything you do, obviously it's important to, address the impairment, but you need to do the task practice, and relevant task practice would be, walking for those who are having trouble walking. But if they can run, maybe we actually restricted them from doing the relevant task practice, which we would normally do clinically of high level mobility. So I think, going forward, clinically, it's just important to make sure you're aligning the relevant task practice for whatever it is you're doing, with the resistance training that you're doing. Just one other comment about, who and when. We actually looked at whether we could do this as a home exercise program, a home-based trial. So that we published that last year, and basically we looked at two things: like, was it safe, and could people do it accurately enough that they're going to benefit? And so most of the exercises, well, firstly, they couldn't do all the exercises at home that they did in the trial because some of them involve some equipment, that couldn't be done at home. But in the paper, it's got an appendix and it outlines all the exercises and what the criteria were for performing the exercises, so anyone could sort of pick it up and repeat it. So for most of the exercises, people could do it safely, which is, obviously important because we don't want people going home and injuring themselves. But the real dilemma was that most of the people, even though they could do the exercises, they didn't do them sufficiently well that they would benefit. So in terms of meeting performance criteria, it was, often quite poor. So, good practice leads to improvement and poor practice, doesn't. So, that was probably evidence for us, that this has to be center-based or supervised stuff, like Chris was talking about, that, neurological adaptation. It's just that constant feedback. And we know lots of our patients might struggle with, self-monitoring, and, they've got lots to think about, when doing these exercises that might sort of seem weird at first. So, it really does need to be supervised, so that, people optimally benefit from, their time they're spending exercising.
Right, we could keep talking all afternoon, but I feel like we probably should start wrapping up. So I guess if I start with you, Gav, I guess what would be your one key takeaway that you'd want people to take from the results of the trial?
So for clinicians, like we did as part of my trip fellowship, actually looking at 12 rehab centres around Victoria, and we found that people, clinicians in rehab centres, are devoting a reasonable amount of time to strength training, which is great. So we're not suggesting you need to do more. We're just suggesting maybe consider it doing differently. So we know you're all busy and we're all time poor, but you don't need to do more. Just maybe reconsider how you're doing what you're doing. So doing fast calf exercises rather than calf raises, for example, like Thommo was talking about. And he also talked about the hip muscles. So knowledge of what muscles are responsible for forward progression. If you're trying to improve walking speed, it's the calf, the hip flexors, and hip extensors. So that's why he was doing those hip exercises. So knowing your biomechanics, knowing the muscle function, and then just trying to replicate how the muscles work with the exercises you're prescribing. So that's the bottom line for me. And this trial might give you some ideas on how to do that. But whether it's most of our patients are in hospital because of mobility limitations, but even if it's upper limb function, just think about the upper limb task and how quickly those muscles have to contract and through what range, and then make up some exercises. And that's what Chris and I have been doing for 25 years is how do we better challenge our patients? And Chris does it incredibly on with bike training and swimming and all these other things. It's just task specific exercise prescription.
Great. That leads on to you, Chris. What would sort of be your big takeaway from this trial?
I would say that traditionally there's been a quite conservative approach to treating our neurological patients, and I think we need to view it as beyond their episode where they've had a head injury. They're medically stable. You can see the age cohort in the study, in this study, is that they're a young group of people, and they will benefit from being challenged. So I think we need to move outside the realm of that conservative approach and really starting to challenge our patients. And again, around the exercise prescription, I think the way to describe it, it's impairment-based exercise prescription, and that's what we're trying to, the way that we're trying to approach it.
Yeah, great. What about you, Tom? What would you want to tell people about the study or your experience doing this type of training?
I reckon that I have benefited greatly from the trial and being a participant in the study, because it got me more physio. And in a time early on in the days of my rehab, more physios were I typically needed, and not just more, but also challenging for the certain types of muscles that are activated more when I'm particularly learning to walk again. Therefore, were lots of calf raise and a lot of hip stuff, because they're big. They're some of your main muscles for trying to walk again. Yeah, I think it's benefited greatly.
Jayden, what about you from the student perspective? What did you get out of this study?
This supports what Chris and Tom were saying. I think it's really easy as a student to just think surface level about rehabilitating a patient, where you just sort of focus on achieving a certain strength or range of motion benchmark, but this doesn't, directly translate into improving a specific task. Where this study that we looked at, it showed how they were targeting specific muscles and specific forces that are experienced when walking, and it did show successful results. So I think for me as a student, it encourages me to think a little bit more critically about the patient and their goals, and how treatment in the future can specifically work on addressing these tasks.
All right, well, thanks everyone for your time. We'll finish up now. Thanks.